Thank you. Thank you, ma'am, for these kind words. And at the outset, let me thank Dr. Bansi sir and Team Diabetes India for this wonderful opportunity. During this post-pandemic session, we are going to talk on hypoglycemia. So that is really difficult task, but and my job is to take you through the non-diabetic hypoglycemia. So before we move, these are the some of the tallest building in the world. You can see the simple equation is energy, power, or success has been always related with the erect posture. So during the human evolution, we always wanted to live happy and healthy life. And that's how the things keep changing and we keep building whatever goes outside, we get immediate attention. That's why most of the now here also you can see the stage is little bit on the upper side. So because the audience should get the proper attention towards the slides or the speakers. So it has been a natural tendency of the humans to see upside position, upright posture, and that is considered as a success. Now, yesterday there was a cricket match in Ahmedabad. So the first testicular guard used in the cricket in 1874 and the first helmet 1974. So it took almost 100 years for the humans to realize that the brain is also important. Now, with this link, let me take you to the hypoglycemia. So clinical features similar to the diabetes were discovered almost 3000 years back, but hypoglycemia was first documented by James Collip when he was working with Frederick Banting in 1922. So it took so many years to realize that the hypoglycemia is also equally important for the human survival. Now, hypoglycemia is uncommonly seen in adults without diabetes mellitus, so that is what the today's topic. It can be clinically classified according to the timing. It can be fasting, postprandial, or exercise related. All the patient should undergo the evaluation and management to develop the symptoms or the signs of the hypoglycemia. That is a typical Whipple's triad, and testing should be performed at the time of the spontaneous development of the symptom. This is very, very important. When we should evaluate, when we need to take a blood sample, it should be at the time of, preferably we should try to get the sample at the time of the event. So these are typical Whipple's triad, the symptoms, then the documentation of the low blood sugar and the relief of the symptoms when the glucose is given. Now, epidemiology, large retrospective trials has shown that the frequency is 36 per 10,000 admissions. So this is done when the patients were seen on the indoor patients. Patients with the age above 65 years on admission were 54% more likely to have an episode of the hypoglycemia. Now coming to the etiology, the non-diabetic hypoglycemia can be broadly divided into the two main groups, insulin mediated. So basically because of the increased insulin secretion or the independent of the insulin. In insulin mediated, we can have an endogenous cause like insulinoma or islet cell hyperplasia. We can have an exogenous cause where the exogenous insulin intake or the insulin secretor valve. So basically these causes are just like a Gharwali and Baharwali. So there are some extrinsic factors, there are some intrinsic factors which influence the blood sugar level. Now, these are the few causes of the hypoglycemia which are independent of the insulin, which is the most common. We know that in Indian scenario, probably we'll exclude the Gujarat state because it is a dry state, but in most of other states, we know that the alcohol is one of the common cause. Then visceral failure, critical illness, primary adrenal failure, anterior pituitary failure, sepsis, cerebral malaria, anorexia nervosa, and some autoimmune disease. Again, as mentioned, there are so many drugs which can cause hypoglycemia, like quinones and anti-malarial, lithium, AC, and ARBs. Non-diabetic hypoglycemia in children deserve the special attention where they are mainly because of inborn error of the metabolism. It includes the glycogen storage disease, fatty acid oxidation, ketogenesis defect, and gluconeogenetic defects. Galactosemia has the impaired ability to metabolize the galactose, and these are the congenital hyperinsulinism. You can see the number of the genes related to this. Pathophysiology is really complex. We know that the autonomic nervous system gets activated as the blood sugar start dropping below 70. So adrenergic and cholinergic response takes the charge, and there is a production of the counter-regulatory hormones. Now, secondary to the exogenous insulin, we could find the raised insulin and the suppressed C-peptide levels in this patient. And secondary to the exogenous sulfonylurea, both insulin and C-peptide levels will be raised. with the positive sulfonylurea test. So this becomes a picture, it makes the picture really complicated, and we know that the humans are really complicated being. Then non-insulin mediated hypoglycemia, again the alcohol is the major cause in states where the alcohol consumption is high, specifically country liquor. Then the liver failure, it diminishes the glycogen storage and impaired gluconeogenesis. And if it is associated with the renal failure, then the hypoglycemia becomes very common. Primary adrenal failure due to lack of the glucocorticoid hormone, there is a decreased glucose production. In cerebral malaria, the pathophysiology is really poorly understood. Ventripituitary failure is basically because of the low levels of the corticotropic and somatotropic hormones. Infections, severe infections, we know it can cause the severe hypoglycemia. We generally see these patients in the ICU setup when the leukocyte count is on the higher side, the patient do develop the hypoglycemia. Neoplasia related, that is because of basically increase in the production of the IGF-1 and IGF-2. Insulin receptor antibodies do have the hyperinsulinemia and uh, causes the hypoglycemia. Now, few situations deserve the special mention. As recently we had a Kumbh Mela, but again, Mela became very famous because of these two. So these two candles deserve the special mentions. Like that, we cannot complete our discussion without insulinoma. So it is a functional endocrine tumor. Incidence is very rare, 1 in 4 million per year. It can be associated with the main one, that is the pituitary, parathyroid, and enteropancreatic tumor. Uh, we generally say that the insulinoma people will have the fasting hypoglycemia, but it's not the case. Fasting hypoglycemia is a hallmark, but it is seen in 73% cases. Both fasting and postprandial hypoglycemia is seen in 20% patients, and only postprandial hypoglycemia symptoms are more prominent in men. So there is some gender difference. So if the patient with the insulinoma and if the gender is male, we could see only postprandial hypoglycemia in this patient. Then the diagnosis is a two-step approach, biochemical confirmation and localization of the tumor. 72-hour fast is the gold standard test. We could see the low levels of the glucose and beta-hydroxybutyrate, raised levels of the insulin C-peptide, and simultaneous negative sulfonylurea test. Imaging CT, MRI, or selective arterial calcium stimulation test. Treatment is surgical resection. Where the surgery is not possible, we need to go for the dietary modification, diazoxide, then glucagon pen, or in some cases, we could try alpha glucosidase inhibitors also. Now, this is going to become more common in coming days, post-bariatric hypoglycemia. Poonam madam is here, so maybe madam must be seeing many cases of the post-bariatric surgery hypoglycemia. It is also known as the leg dumping syndrome, relative hypoglycemia, or the postprandial insulinemic hypoglycemia. It is mostly seen in the RYGB surgery, but can be seen in a patient with the sleeve gastrectomy or the laparoscopically adjusted gastric band. Prevalence is between 0.1 to 34%. Risk factors: female sex, RYBG surgery, longer time since surgery, and absence of the pre-existing diabetes. Again, the probable mechanism, the accelerated nutrient emptying, enhanced enteroinsulin axis activity, then the postprandial hyperinsulinemia, and there are some non-insulin dependent factors like reduction in the counter-regulatory hormone response, increased glucose response effectiveness. This is how we should go with the workup of the patient with the post-bariatric surgery hypoglycemia. So this is a very busy slide, so I will not go into the details because of the time restriction. Now, this typical animal, as I initially stated, that the humans are evolving to survive, and we made every attempt to make survive, but we forgot this animal. This is called as a tardigrade, and you can see in this extreme temperature, extreme condition, these animals survive. So, if you could have focus on the research of how this animal is surviving, probably आज तक हमारा lifetime 300 years तक बन जाता, but somehow we miss this. Now, again, coming to the workup of the patient with the non-diabetic hypoglycemia, history and physical examination, we should document the age of the onset, nature, existing of the underlying illness, conditions like other comorbid conditions, any concomitant drug use, family history. If there is a weight gain, there is probably insulinoma, weight loss, probably we should think of the malignancy. Then the hyperpigmentation, we should think of the Addison's disease. In infants and children, hepatomegaly uh, is hallmark of the glycogen storage disease when associated with the hypoglycemia, seizures, hereditary fructose intolerance, weight loss, vomiting, and cataract, galactosemia. Just last 1 minute, time is up. And short stature. The timing of the hypoglycemia is very, very important. So we should document the timing of the hypoglycemia, whether it is fasting, postprandial, or what. In evaluation, we should do routine blood test, but again, beta hydroxybutyrate and IGF level, if required, we should do. Uh, in bone marrow metabolism, I will skip. Again, as I said, that we are always as a humans, we want to see the success and the tall stretcher. So this is the simple picture. If any could anyone could spot the difference, I think there is very difficult to spot the difference, and everybody will agree that the first attention of the mind goes to the power. So that is how the human nature. There is only small dot on the right side. These are the mirror images, so there is absolutely no difference. So in differential diagnosis, this is again very important aspect. Low asymptomatic glucose or the sample is taken without antiglycolytic agent such as fluoride in a blood collection tube or delayed processing could lead to the low readings. Patients with the leukemia or the severe hemolytic disease due to rapid glucose uptake. Symptomatic nocturnal glucose, it can be because of the cardiac disease, hyperthyroidism, pheochromocytoma, or sometimes psychiatric disease. Complication, we know that there are a lot of complication with the hypoglycemia. It could lead to the death and the quality of life is really bad. So take home message, hypoglycemia in non-diabetic individuals was a significant diagnostic dilemma. Differential diagnosis is extensive and the management depends upon the cause. Requires careful evaluation. Timing of the hypoglycemia is very, very important. Post-bariatric surgery is becoming commonly in a non-diabetic hypoglycemia. In professional healthcare approach, so team approach is important and clinicians should be aware of the differential diagnosis of the non-diabetic hypoglycemia. With this, thank you very much for your patience listening. Thank you.